Okay, so let's move on with another question. We have an 8-year-old, 24-kilo girl who's in septic shock and developed ARDS. She's on mechanical ventilation and currently sedated and paralyzed with an FiO2 of 0.6, tidal volume of 240, SIMV rate 25, PEEP 6, flow rate of 30 liters per minute. The PIP is 36. 1 second following airway occlusion, the pressure is 32. Her ABG is 729, PO2 is 95, PCO2 is 34, the SAT's 99%. What is the next appropriate step to optimize her outcome? So A, you can decrease her respiratory rate to allow the CO2 to come to normal of 40. Increase her FiO2 to 1 to maximize oxygen delivery. C, you can decrease the FiO2 to 0.5 to prevent hyperoxia. D, you can decrease her tidal volume to 140 mLs, which is 6 mLs per kilo. Or E, you can stop paralysis and perform a spontaneous breathing trial. And so the correct answer here is to lower the tidal volume, right? So you're dealing with a tidal volume that is fairly high, it's 10 per kilo, and as a result, you have a very high plateau pressure. That's what the 1 second following airway occlusion is telling you, which really is telling you you're overventilating non-compliant lungs and potentially over-distending them and setting them up for failure. So here you see that the correct answer takes into account what the driving pressure is. And driving pressure is just the difference between the plateau and the PEEP. And in this case, that driving pressure is 26. In adults, we have some pretty good literature from a large observational cohort from the RCTs that were done in the ARDSNet that basically anytime your driving pressure exceeds 15, that's associated with worsening mortality. In pediatrics, higher tidal volumes and plateau pressures have been associated with worse outcomes when your plateau pressure gets above 30, and in some studies as low as 27. So basically reducing the tidal volume to reduce airway pressures is the key to optimize your outcomes. The rest of them are just incorrect for a variety of reasons, and I'll let you read those. So what I want to get to here is scalars and loops. So the key way that you're going to be tipped off to how your patient's doing on the ventilator is by appreciating the scalars and the loops on the ventilator. And generally speaking, the scalars, which are showing you flow, pressure, and volume over time, so the axis down here is time, are the things that usually are displayed. And then often for the loops, and the two loops that we frequently look at are pressure volume loops and flow volume loops. Those are often going to be things you're going to have to dial up, although different screens now, ventilators can allow you to have whatever display you want, so you can actually get all of these if you want. And there's a lot of information you can derive from these scalars and from these loops. So here I'm showing you a couple examples where you have over-distension and you get beaking within the loops here, and in the pressure volume loop. And in the case of the flow volume loop, when you have air trapping, you see this kind of scooped out appearance during expiration, which should be kind of a steady exhalation. And so the loops can be quite helpful by picking out these patterns. The scalars tend to be a little bit easier to pick up some stuff on, so I'm going to spend a little bit more time on the scalars. So let's start with the concept of compliance, right? So what happens with compliance is essentially, as the lung gets stiffer, what will happen is that when you do a pause in inspiration, then essentially the air that you've already given tries to redistribute in the lung. If the lung is really stiff, it can't really redistribute. So the plateau pressure, which is that pause pressure, ends up being not very different from when you started it, whereas if you have a really compliant lung, it'll drop down quite a bit and the plateau pressure will be fairly low. So here what you're seeing is during an inhalation, there's a pause, so you're holding the inhalation, and then you have exhalation, and notice that there's no flow during this time, so the flow is 0, and this is your baseline, and then you get exhalation afterwards. And during that time, the pressure is something, and depending on what this number is, it tells you whether or not the lung is being kind of over-distended and whether it's stiff or not, depending on the ratio of the volume to the pressure. So basically, it's important to recognize that the peak inspiratory pressure is different than the plateau pressure, and in fact, how big that difference is tells you something about resistance versus compliance. So this is, first of all, kind of a normal tracing where we've done an inspiratory pause. And so in this patient, the PIP isn't all that high and the plateau is just a little bit lower, and then you release it and it exhales. In this patient, you have a really high PIP, but a plateau that's at a kind of nominally normal level, right? And so having this big gap between PIP and plateau implies that airway resistance is really high. And when you stop flow, essentially the resistance component drops off and you're just looking at the compliance portion. So this is tipping you off that you have too much resistance. So this might be bronchospasm, this might be a tube kink, this might be a tube that's too small in a patient. In this case, you have let's go to this example. You have a patient who has a high PIP, but really it's mostly being driven by the plateau. So notice the plateau is almost as high as the PIP. And so this is really a low compliance situation. The resistance isn't too bad because this difference isn't bad, but the compliance is quite poor. And anytime the compliance or plateau pressure goes up, the PIP always has to be at least equal to, if not higher than, the plateau pressure. So where is this going to be useful for you? You as an intensivist are going to get tipped off by a high pressure alarm, right? So it's the PIP that's alarming, right? Because it's too high. But then you have to figure out, why is the PIP too high? Is it too high because the plateau's too high and it's driving it up? Or is it because there's a resistance problem and the PIP's high and the plateau is actually normal? So doing a inspiratory hold is one of your ways to diagnostically figure that out. And by the way, to do this is done in a volume control mode, right? So in pressure control, it's a different strategy. And since it's a monitoring lecture and not pulmonary physiology, I'm not going to get into that. But these tracings are all from volume control modes, right? In this situation, what you have is something that looks a lot like this one, right? So this is a patient who's getting really high flow. So let's say it's an adult and you have an I time of 0.4 seconds, right? Which is really short. So that means you're ramming in the breath really quickly. In that particular patient, it's going to look like the resistance is high because you're shooting the flow through a period of time that's kind of too short, and thus the resistance becomes important, right? So really these are identical. So whether it's high flow or not, you kind of have to look at what the flow is and decide whether it's appropriate, and then you can decide whether it's really a resistance problem or is it a flow problem. So again, it's not a pulmonary lecture, so I'm not going to get into all the things that get into psychoasynchrony on a ventilator, but the point is that there's a lot of issues, including patient issues, including ventilator issues and settings. And the only thing I want to tell you from this monitoring lecture is that you can be tipped off that asynchrony is present by looking at your waveforms. We talked about how capnography can help you do that, but then the waveforms on the ventilator also help you to do that, okay? One of the things that you definitely have to be able to spot is the presence of high intrathoracic pressure from air trapping, okay? And that looks like, or that shows up in a couple ways, okay? One is if you have evidence of incomplete exhalation. So here, this is the flow time scaler, and what should happen is this. So C is basically more of a normal looking exhalation where you have inhalation, so you go on flow, in this case is square wave flow, and then you exhale and the exhalation quickly goes to peak exhalation, and then there's kind of this exponential curve. And notice that when the next breath starts, you're already back to your zero, your baseline. In this case, somebody turned up the respiratory rate, and in doing so, they shortened the expiratory time. And notice that by the time the next breath happens, you haven't fully exhaled. So you're leaving behind a portion of air. And so you can imagine what's happening in the lung is a little air is being trapped with each of these breaths, and the lung volume keeps getting bigger and bigger. Now this can't go on forever, right? What's going to happen is as the lung volume increases, the pressure in the lung is going to increase, and one of two things happens. Either that pressure kind of causes a back pressure and then forces exhalation to happen faster, right? So you get a higher peak flow and a quicker exponential decay, and then you hit equilibrium, or you pop a pneumothorax, right? So one of the two will occur. But anytime you see this pattern of incomplete exhalation, it should tip you off that you may have auto-PEEP, okay? And how do you measure auto-PEEP? Well, auto-PEEP is actually measured by doing expiratory hold maneuver, which is what I'm showing you on the bottom here. So in the expiratory hold maneuver, similar to inspiratory hold, once the patient's done exhaling, you hold down usually it's a button on the ventilator, and it does a hold. And notice that here, as you did it, you had a pressure that all of a sudden went up during the expiratory hold. And so this is implying the fact that there's some additional pressure left behind is implying that there's essentially an unaccounted for PEEP, which is the pressure left behind in the lungs. And so the total PEEP of the lungs is the external PEEP, whatever you set, plus this intrinsic PEEP that you're measuring through an expiratory hold. Now, to do an expiratory hold, you need the patient to cooperate, meaning that they can't try to then take the next breath because that'll mess up the hold, right? So you got to have a patient that, generally speaking, has to either be cooperative or be deeply sedated, more often the latter, where they're not going to try to trigger the breath again. Obviously, if they're paralyzed, it's very easy to do. But both of these maneuvers that I showed you, the inspiratory hold and expiratory hold, if the patient's breathing forcefully or rapidly and making a lot of effort, they become completely invalid because unfortunately they just screw up the numbers where you can't count on them. One of the things that ideally you should be able to pick out in looking at waveforms on a ventilator is a patient who's trying to trigger and can't. So we already showed what that looked like on the capnography. A very similar thing happens on the flow, where here this is expiratory flow, and remember we said you get a peak and this should be a gradual exponential decline in expiratory flow, but notice here that all of a sudden the expiratory flow goes to zero. Doesn't get above zero, right? If it did, the patient would actually be successful here at triggering the breath. So they're trying to trigger the breath, but they're failing, and so then they go back to exhaling, but this is essentially a failure to trigger. So every time you're seeing this, the pressure waveform is going negative, the flow is coming closer to zero, okay? Generally speaking, you're going to see this dyssynchrony first and foremost within the flow waveform. Sometimes you'll spot it on the airway pressure. Depending on how strong or weak the patient is, you may not see a significant pressure fluctuation, but you'll definitely pick it out here on the flow waveform. Other things that are present. So if you set a patient's eye time too long for that patient, you essentially force them to do an unintentional hold every time. So if you see what looks like a plateau on every single breath, and this is just showing you the flow pattern, but the correlate of this would be on the volume scaler, you see a flat top, okay? So the volume tracing, we rarely look at the volume time scaler, but really it should look like a mountain, right? It should go up and come right back down with a peak. If there's not a peak, if there is a hold like this, a plateau, that's telling you that your eye time is longer than what your patient needs, right? So what's happened here is they've basically hit alveolar pressure equal to airway pressure, and so there's no more flow, okay? The next thing to look at is just if you're looking at your airflow pattern and you see kind of doubling up like this, right? This is a double stacked breath, right? So this is a patient who is actually, if you look at the pressure tracing, is trying to make an effort here to get a breath, and then they're failing, and then eventually what's happening is the reason that the pressure is so low is they're forcefully breathing throughout this respiratory cycle. And so when this respiratory cycle ends, they're still trying to breathe in, right? So the pressure never really rebounds, and then ultimately they manage to trigger the vent a second time. So here, this is somebody that either needs a longer inspiratory time to make up for this desire to take a longer breath, or often these patients actually want a bigger breath. So it's not necessarily that they that the eye time's off, but it might just be that the tidal volume is just too low, and so they're taking longer breaths trying to get more air, okay? So these are all patterns that tip you off to dyssynchrony. There's a lot more of this in ventilators, but hopefully I identified some of the low-lying fruit that's going to be more common and useful to you both in your practice and in the boards. Okay, and that's our last slide, so we'll wrap up and pick up with some of our additional monitoring in the next lecture.